in which we covered basics of colposcopy, and in the second webinar we had scoring. We had a nice discussion on scoring systems. So now let us move ahead to the third part of this wonderful webinar web series, and today we are going to cover on the therapies of cervical intraepithelial neoplasia. So to start with, I welcome our chairpersons for today's session, Dr. Yamini Alsi ma'am and Dr. Suvarna Joshi. Dr. Yamini Alsi ma'am, she's a senior consultant gynecologist, and she was president of.
Slides focus kar Rujita.
Next slide. Hello, team IT.
Jignesh असेल तिकडे.
Please start the slideshow.
जिग्नेश, चेयरपर्सन्स के सीवी पे फोकस करो.
मैम एक सेकेंड.
Dr. Alsi ma'am, she's a senior obstetrician, and she was president of Nagpur Obstetric Gynecological Society, AMWI, as well as NACHI, and she's actively involved in cervical cancer screening, and she runs a colposcopy clinic since many years. So I welcome you, ma'am. Dr. Suvarna Joshi. Dr. Suvarna Joshi, slide please. CV slide please. Dr. Suvarna Joshi is a consultant obstetrician and gynecologist in Orivision Nursing Home, and she has areas. She worked as assistant professor in the Government Medical College Nagpur, and she has special areas of interest in preventive oncology, as well as fetal medicine and high-risk pregnancy. So I welcome you both, Dr. Yamini ma'am and Dr. Suvarna Joshi ma'am. Hello.
Hello. Suvarna, you can introduce. Is Suvarna there? Okay. Good evening, everybody.
No, Suvarna. Mute.
Unmute करो Suvarna madam.
Unmute कर. Suvarna, we are not hearing you. You are still muted.
Can you hear me now?
Yes.
Yes.
Thank you, Dr. Rujita. We'll start with the session outrightly. Before that, I'd like to give a small introduction of Dr. Priya Ganeshkumar. She needs no introduction. She is a teacher par excellence, and you know, her teaching is like, she's very passionate about her teaching, and her teaching is in that subject which is very close to heart. And she's also right now the chairperson of the Gynecologic Oncology Committee, FOXY 2021-24, a recipient of many awards and recognitions, who has many books and publications to her credit. She runs the mentorship and training program for IFCPC colposcopy all around India. She's held many key positions, and we've been listening to her since last 2 Mondays. The sessions have been simply too informative, and we expect the same same zeal and the same output from both the participants as well as the ma'am as well as Dr. Priya Ganeshkumar today. So welcome, ma'am.
I would like to say about Priya, her logo is Swasth Sundar Nari, prevent the preventable. That is mostly what she is working on that. And we have learned from her basics of CIN in the first session. Then we are scoring. Once we diagnose a patient with cancerous, we cannot leave a woman without just diagnosing her. So we must do something, and that is our slogan, WHO 90, 70, 90. So 90% women should be treated and followed, and that is what today is the topic. She is going to, Dr. Priya is going to talk about therapies of precancerous lesions. Priya, please.
So thank you very much. I'm back at NOGS, and yes, we have been having a wonderful sessions. Last 2 weeks were really good and a lot of enthusiasm from the participants, and of course, it's also a good teaching and learning experience for me too. So now, as Yamini madam said, like we just can't leave, right? I mean, identifying the CIN and then leave it. That cannot be done. Plus, in the same thing, we can't even overtreat. We shouldn't overtreat. Because what's happening is, in our country still, the fear factor is terrific. You don't know when to do, what to do. And then by having a word, dysplasia itself creates such a big jitter that, you know, sometimes over-treatment has been done many a times, rather why sometimes, many a times. And hysterectomy, for that matter, becomes even more... Ganesh?
Jignesh.
Yeah, the network is fluctuating. I'm so sorry about that. So I'll be sharing my screen, and hence we do not want any over treatment or under treatment. So let us understand from today's deliberation when to do what are the modalities of treatment, and then you know, I've also brought for you ASSP guidelines, I've brought for you WHO guidelines, and I've brought for you cases also, depending on those algorithms. So this is going to be a through and through lecture on therapies, case managements, and you know, how do you take it up, what is the follow-up, and that's how we are going to go for today's deliberation. So whenever you talk about a case management, it's always, you know, you are not dictating the term, whereas you're discussing the things, the balance versus, you know, benefit. You're actually scoring a balance between a benefit and the harm. And you are also, you know, trying to discuss with the patient rather than creating a fear factor into them. So the methodologies which we discuss with our patients are the ablative and, you know, excisional methods. So whenever we are talking about, just a minute, just a minute. This charger, it's not charging. Yeah. So ablative is you're totally ablating. Excision, but you do not get any histopath along with it. But if you're doing an excisional biopsy, you are excisional therapies, you are getting the biopsy for histopath as well. These are the two major things. And now we'll take one by one. We'll discuss at length how do you take it up. Now, whenever you're talking about ablative methods, you have two basic methods, which are your thermoablation and your cryoablation. So let's talk about the thermal ablation first. And Kurt Sem used it in 1966. It was so old, you know. And originally, whenever we are talking about it, you know, as this is a misnomer called cold coagulation. No more we are using this term as cold coagulation. We are always saying thermal ablation. Why that cold coagulation terminology came up? We have to ask that. Why did people, first of all, start with the cold coagulation terminology? Because those days, it is in the last few centuries back also, we were using those branding and heating technologies. So comparative to that, now this is little cold, and that's why the term cold coagulation, but it is not right. Why we are saying thermal? So it's not cold because we actually heat the probe. It's a preheated one till 120 degrees. And then you apply. So you can apply multiple times as well. And you have to apply it for 40 seconds at 100 degree and above centigrade. So whenever you're using a thermal ablation, you have this thermoprobes with you, and they are with nipples, they are flat, they are, and you can, you know, easily clean them. You can put it up into the Sidex. I normally clean them with the formalin or the Sidex, and then put it up in the formalin chamber. And they can be detachable and clean. So this is the whole console that you have this. Now, even now it is more easy. This PPT is few years back, but now what I'm using is a handheld one. Now that's more comfortable also. So what is the principle behind a thermal ablation? The principle behind is the intracellular water gets desiccated, thereby denatured, and hence the CIN tissues are in fact washed away. And let's see the video behind this. So now you see what we are doing is, first of all, this is getting preheated to 120 degrees. So you have that beep coming up. So once that beep, beep, beep stops, you know that now it is preheated. Then you have sheath to it. Now this sheath, you can just withdraw it. Once you touch the tissue, you can withdraw it. And then you have the heated one. Now this is hot. So then you again put the timer on. Once you put the timer on, 30 seconds may 1 beep, and then 10 seconds 1 beep. So what is the principle? You can see the blanch over here. This doesn't require any anesthesia at all. The patient is comfortable. There's no need to have any this thing. So these are used in see and treat programs, and rather through government also we have an approval that you can use this in the GOI guidelines also. You can use thermal ablation. You can use it multiple times. So there is no refilling of the gas required. It can be operated on electricity, but now battery operated it is there. Low learning curve and can be used for see and treat. What is the disadvantage of this thermal ablation? Now, the main thing is where to use it. You will use it. See, ablative procedures criteria is what? That the lesion should not be more than 75% of your cryo probe or thermal probe. Now, for thermal probe, you can always apply it, multiple times. That's not a problem. And another thing, this thing is, it should not be an endocervical factor. It should not be an endocervical lesion. No iota of endocervical lesion into it. Thirdly, it should not have any suspicion of cancer. So these are the major this thing. So whenever we used to talk about cryo ablation, we have been using cryo cauteries since so many years and so many decades rather now. There was always a limitation in cryo that if the lesion is large and I cannot use it, then should I go for a, even though if it is a SIN1, SIN2 lesion, should I go for a LETS or excision? So that thing portion has been now covered after getting thermal ablation into our kitty. And so you can apply it multiple times. So the purpose is the SCJ should be completely ablated. Remember that, friends. So use a probe which is bigger one or suiting your, the lesion size. See to it that the SCJ is ablated. But the only disadvantage is no tissue biopsy. You don't get the tissue biopsy for it, because you're ablated it. So what will you tell the patient now? You will say that no sexual contact for 3 weeks. Then, they need not do any douching. They need not apply any gel or anything. And there can be a little darkish discharge which can come up. And another thing is, even if they have a menstruation in the interim, let them not use those vaginal cups and tampons and all that thing. So that area is raw. And hence no sexual contact, because otherwise it's an open area and HIV, HPV infections can become very rampant. So all these advices to be given, no douching, nothing, no splitting water, splashing water into that area. So this is very safe, and I've been using thermal ablation since long time now. It is one of our favorite instruments, and whenever we do a lot of camps and all that, right, we take this along with us. Like the other day, I was at ICOG workshop, Googly workshop of Uday Tanawala, and I was showing them thermal ablation out there, and on the live tissue, and it was like, it was wow. I mean, this thing required, and it's all battery operated, so it becomes very easy tool. No big one. So another now thing which has come up is, which we have been using, is cryocoagulation, but now cryo probe is another technique which has come. Now I'll be telling a little bit about that, because it has just recently been launched by JEPIGO, And I had the this thing of using it because they had also taken part in that Googly conference. I had only instigated them to take part because it was a where they can showcase their instruments also. And that was with CO2. So let's now go to cryoablation and let's understand this. It's a safe ablative procedure. You can use nitrous or carbon dioxide, and the freeze thaw freeze is the cycle thing. Like in the first edition, when I wrote my CBS publication book, which is with MUHS reference textbook, those days, this was in 2015 when WHO had come up with 3-2-3 they had brought. Rapid freezing, slow thawing, but rapid freezing again and all that thing. Then there was a time to write my second edition. And again, I understood that, now WHO is saying 3-5-3. Then when the time came to write my atlas, at that time, I really wanted to know what exactly is all these things happening and what is the meta-analysis study saying. So when I did a little bit of a research into meta-analysis, I came to know something really very important and very useful as a practical way where it is useful. I'll tell you that. So 3 minutes of freezing. See, we all have been using cryoablation. I don't think so. Even you might not have a colposcopy, but people do have cryoablation with them. I mean, I'm traveling across the country. I know people do have. But the only thing is, you should know where to use it and how judiciously you should be able to use it. So let's understand the prerequisite type 1 TZ, fully visible ectocervical lesion, 2/3 within the eyes ball, and it treats by crystallizing the intracellular water of the cells, thereby denaturing it. And what is the thing? How will you explain to your patients? You will say that there are certain local terms which are used, like Thandi Sikai, Garam Sikai, and all that in North. I have a facility at North as well. So there and all is very common, And yesterday I was with Haryana OBGYN group, and I came to know something very, very, strange. I mean, that's the protocol which they follow, it seems. That anything white discharge coming up across to them and treated after so many antibiotics, leave apart whether it is an ectropion or whatever. Now they have been calling erosion for ectropion and all that stuff, but that's noted fact. But surprisingly, they said that they have been doing cryo for every white discharge and they're getting a good results. I mean, this was something, a very eye-opener thing for me. And I was also very shocked, and I tried to put up my argument out there saying that how can that be? Because cryoablation or thermal ablation, what does that do? Even if there is no lesion, whenever we are using it for lesion, we are using it, I do understand very correctly. But whenever we are using it for the physical, transformation of metaplasia, definitely there has to be a huge TZ1 or an ectropion or an ectopy. Then, of course, you have seen that, and which people call erosion. And as I told you in the last 2 lectures, I've been telling consecutively, and in all my lectures, I say, please stop telling the word erosion, because there is nothing called erosion in the terminology of, CIN. In an IARC also, where they say erosion is whenever really, truly there is an ulceration and there is a breach of skin, then you call that as erosion. Otherwise, it's an ectopy or an ectropion and all that thing I've explained already. So if a patient comes to you, say around 38 years old, and she has a huge ectopy, and you are another case where 26 years old, again a huge ectopy, both coming up with white discharge, what will you prefer? So in a 26-year-older, you will tell her, right, that is a physiological transformation has yet to occur. So you can always do her pap test and just check out on her whether there is any lesion or not. Treat her properly and just give an advice. You can send her giving a probiotic or something like that. And even suppose if she truly has an infection, you treat her. But in a case of a 38-year-older where still the ectopy is persisting and, she's coming up with a real huge profuse discharge. Of course, I do understand there the reserve cells, totipotent cells hasn't taken up. The metaplasia hasn't turned up and it hasn't occurred. Hence, you are trying to give an ablative procedure for actually, giving a sort of a shock treatment or, the resting cells, so you're just triggering them. So that's a different story. But whenever we take a thermal ablation for treatment, then your requisite has to be completed. So now let's go to this video and try to understand what exactly is all. Now, so here we have this cryo gun, and we have this attached to nitrous. So please see to it that your nitrous cylinder is full. Okay, now that's very, very important. And if it is not full, then you might get a halfway treatment and you will get failures, I'm sure for it. And when you are doing this treatment, you should be, you yourself, because once you really start doing treatments, out of your experience, you will come to know what is the grip and how soon did that grip fall off. I mean, that defrosted and your gun fell down. Depending on that itself, you can speculate that, yes, this treatment has been adequate. So the timer for thawing doesn't matter. So you have freezing for 3 minutes, you put the gun, see to it that your lesion is within that, okay? Whenever you're attached it to the console, and the manometer should be showing in the green, that kata should be in the green, that needle. If it is there in, say, red and all, that means it's overfilled cylinder. You can, just little bit release it. And if it is in yellow, you know that it is half-filled cylinder. So you have to change it. Many a times, the problem with the cryo gun is we are not taught how to handle and clean the probe. I have seen this. We are using it very commonly, but how many of us have truly opened it, cleaned it, seen the visor inside? Many times it just happens that all the nitrous oxide is coming onto your hand. I'll tell you a funny example what happened with me. This is, I'll tell you, in my Delhi clinic, where I was actually treating my staff, the receptionist, and for her, it happened only for her, and sometimes it happens for your own people. The nitrous is not flowing out at all. The nitrous cylinder, twice we have changed and everything, it's not happening. And when I'm opening the sheath, all the nitrous is getting filled up into that little wire, that visor. So the visor is also normal. So many times these problems can occur because this can be choked. That gun can be choked, or that probe can be choked. So please see to it. But then we had to give it for, servicing. So this happened once in a while, but of course, we normally check the visor and everything. So now what we have done this adequate freezing, right? What is the temperature inside? The temperature inside is minus 60 degrees centigrade. And what is the temperature outside? Minus 20 degrees centigrade. How does it help? It actually crystallizes the intracellular water, thereby denaturing. All right. So this is something to be understood. Now, how do you now reapply? When should you reapply? That's again a question. The timer, you can be very relaxed. It can be from 3 to 5 minutes. The main thing is, let this frost be defrosted, come back to the pink color, and then only you apply. Thereby, you get a very effective, that can take from 3 to 5 minutes. Wait for the color change to occur, and then only you apply for the second time, which we have done over here. So now this is a whole console with and your this attachment should be in the right manner. It should not be the other way around. That's also very practical. And I have, since I've trained more than 1,000 gynecologists, I mean, I know what exactly are the practical difficulties when a candidate comes for teaching, for learning from our end, and we actually make them fit the cylinder. Because usually we aren't in the habit of fitting, right? We ask our staff nurses, and staff nurses, whatever they know, they do it. But I have seen, out of my experience of past 3 decades, I have actually seen that many a times the nitrous is not flowing smoothly. Why it is not flowing smoothly? Many a times there is a leakage from here, hissing sound, and you're holding here, and then your complete, on the gloves, you will get all those nitrous. But here, the adequate nitrous is not blasting out. So check on all those compliances. You can apply twice. You can definitely, we can. And it is very simple, it doesn't require any specialized help professionals. But understand, dear friends, to get an effective cryoablation, you should know how to place your cryoprobe. And you should also be, very this thing that prudent to see that you take a fresh cylinder. That's one of my advice. If you have the small nitrous cylinder, we have kept for small nitrous cylinder only for cryo. So we don't goof up with our bigger one that we use for our laparoscopy purposes. So we can be rest assured that this cylinder is kept for that, and it's full. So cylinder should be completely full. It cannot be performed in HSIL or type 3 lesions, cannot be performed in microinvasive or glandular lesions. Coming to the excisional part now. Now, excisional part was coined in, initially, many a times I have this question, Madam, what is LEAP and what is LEGS? Let's understand LEAP, keep that thing for a biopsy purpose. Keep that word for biopsy. But when you are talking, the technique might be the same, understand, dear friends. But in LEGS, we are removing the whole of the transformation zone. That's very important, because when you're treating, you are supposed to treat the whole of transformation zone. So LEGS was coined in the early 1980s using low voltage diathermy loop, using thin wire under local anesthesia with blended diathermy. This was actually coined. And because Ramekarte was using in early, before in 70s and all, he was using it for biopsy. So there was a little bit of confusion, and based on the principle. Now, what's the principle which is by which we are using them? We are using a monopolar cautery, right? And the principle is whenever you're putting an electricity, many a times there is a twitching. You see, you get a shock also. There is a muscle twitch. But why is it that when we are using a large loop excision, or when we are using this electrical, this thing probe, why is it that there is no twitching of the cervix? So the principle is, we are actually, the Faraday came up with this idea that, this thing of electricity, that when you pass an electricity with a high frequency, more than 100 kilohertz, it is the tissue allows, your body allows the safe passage of electricity through controlled surface, and it doesn't twitch. So what is our ESU giving, that is electrosurgical unit, our cautery machine giving? It is putting the electricity to the frequency of about 300 kilohertz, and that's how the contraction is overcome. And there is a whole, monopolar cautery, and the whole circuit is completed. So we use cut and quack together to give a blend cautery, and so let's see how we actually use it. Now, before this, I would like to tell you that, there is a principle of how you use a LEGS. You have to create a small window, you have to give a fulguration current, and then go very slow. Even for cutting a small tissue, it might take 20 to 30 minutes. Go really very slow, and you will get a wonderful LEGS. I mean, there need not be a bleeding at all. There will not be any bleeding if you truly go very slow, and you have been creating a window, a fulguration, you're using a fulguration spray principle, and thereby there is a coagulation beforehand itself, even before you touch the tissue. So you have to be, you have to take the right electrode size also. That's also very important. See, the electrode size also depends. So now normally in the market, and you should be having all the types. And if you want to really practice preventive oncology and practice this in a proper way, there is 2x2, 2x1, 1x0.8. You get these electrodes. Like for me, I've been using my own electrodes, as I told you last time also. I only believe into my own instruments, and I've been using my own instruments. We have Srivari Medical Equipment Company I've erected for this sake, so that I get my own instruments completely, without any hindrances. And that's how, and other people are also benefited because of the step which I took. So many of my doctors who get training also, they are very happy that instruments are available, madam. So we are happy. So in my case, what I've done is I have built up even one more electrode, which is not there in the market. So there I have built up for, for covering up for cone, for conization. So there, my depth of my tissue should not be more than 10 mm. This is one thing which you will have to understand, because otherwise you can have a sort of, preterm labor. The complications are those things, preterm labor or hemorrhage. So if you don't want all those complications, and but if you do not want to do conization, see how many of our private gynecologists, leave apart the doctors who are practicing in a good setup, like you have a medical college and you're doing a conization, that's okay. But I know as a trainer for many gynecologists in the country, I have understood one thing is not many people are doing conization. So how will you have an effective treatment with LEDs? You have to have an effective treatment, isn't it? So that's why I have where I have say 10 mm and a width of say 2.5, so that I have a whole conization. So these are specifications. You can make your own electrodes. It's not a very major thing at all. So now, how do you start a leap? First, you have told the patient, you have advised her, all the things said and done, which we have already covered in the last chapter, this thing episode, where we have told that yes, how do you counsel a patient and all that. Now we are, whenever understand, dear friends, one thing which I want to tell you all. What is the routine trend in the current scenario? Everywhere, I'm talking of pan India. As I get candidates from pan India, and even globally also get candidates. So even in Dubai, like last time I had a doctor from Dubai, she said there again, it's like, you all do this, you all do this colposcopy, then she will come, she'll be posted for LETs in a few days from now, or whenever that insurance has given her the okay thing. And madam, we take her into OT and we do LETs. I had to then correct her. I said, please do a repeat colposcopy while doing LETs. Why so? Because many times it so happens that you would have seen it if you wouldn't have taken the whole transformation zone. But many times it is like you are not daring to take that whole transformation zone out. You are just trying to, concise yourself. I would really request your dear friends, if you're doing it, do wholeheartedly. Remove, take the big one and really cut it out, so that you don't remove, you don't, miss out on those tissues. Like in this case, I'll tell you, this case is a very funny case. I here am treating post 1 month ke baad, like, colposcopy was done. Her lesion was very small. And now you are seeing the lesion so big. In 1 month, this lady from Sin 2 had become Sin 3. Had I just taken my the colposcopy report after 1 month and I would have come for treatment, maybe I would have missed out this case. Now these cases are, now you see, where is a lesion? Huge one. What am I doing? I'm using a insulated cuscos. I'm using this needle, and now this is a spinal needle, 22 gauge. I can also use a dental syringe. I'm using 2% xylocaine. I have used all types to get myself convinced what suits my practice. I had used 2% with adrenaline, 2% with vasopressin, everything I tried. Initial days I used to do with a short GA, but then I thought, no, there's no point in doing all that. It has to be done by local. So what I did, see, you can see I have been giving everywhere. I have given this anesthesia and local anesthesia, 2% xylocaine, and very conveniently and comfortably I've given 20 cc for that matter. I'm using an insulated cuscos which is connected to a smoke evacuator or a simple suction machine. Now this is the electrode which already I use a blend cautery. I use cutting and quack together. So initially, before even touching the tissue, I do a fulguration technique. And this technique truly helped me. And that's why today we are noted for LETs in the whole of the country. And when we are taking these workstations, when I teach the fellowship courses, this is what is taught with, hand holding, how do you take it and all that stuff. So this is very important for us to know how to create a fulguration. How much distance should you keep your electrode, live electrode, active electrode, even before touching the tissue? With a quag little high, I keep it at 60 and then cut 40. And then when I touch the tissue, I make it 50-50 or cut more for 60 and quag little 40. So all these things has gone with experience, of course. And after doing so many LETs, we have come to this conclusion that, and this was by Prendivili, this fulguration technique was actually brought through with Prendivili. And go very slow. This is a cropped up video, so you can see that it's going. Take the full depth, take the whole advantage of the whole depth. So it will be, say, around 2 by 1 centimeter. Now, whenever you're doing also, you will take a pass from down to up or side to side, never from up to down. Now, here what I've done, now this tissue is remaining, right? So you have to take a second pass and cut this off also. Now you see, I'm taking a second pass and I'm going slow, and you have to go beyond the lesion. Now, whenever you are giving for histopath, what are you supposed to see? You're also going to see the lesion margin. I mean, is the margin involved or is the margin free and all that? And then you use a ball cautery and you nicely coagulate it. No need to put, say, again, I'll tell you, with all, everything is learned with experience. Book and all is okay, lectures are all okay. Only when you start actually handling the cases, you come to know many things. Patient only teaches you. So, Moncel paste can be put, or, I learned that putting a simple ball cautery should be enough. No need to put an Abgel, no need to, everything was done before, but never even do, never please put your, what you can call, a pack and all that. Don't do those businesses, because you will never know if there is a bleeding and it's concealed bleeding and what happens to it, like sort of thing. So that's one thing. See, I brought cases for you. Now here there is a lesion. This is a Swede 9, and you can see this, and fantastically going ahead with, here I've taken side to side pass. You can see the pass has been taken from side to side. And the lesion is quite big. You can see this. She comes for follow-up. How do you do a follow-up? I'm going to take you through all those also, like how do you do a follow-up and all that stuff. So we normally call her up after 6 months to do a relay colposcopy, and after 1 year to do her test of cure. So here you can see there is no lesion, and the lesion is completely cured. So now I'm going to take you through understanding that therapies. I'm going to take you through few of the protocols. Let's now understand protocol. Why am I doing this thing with you all is I really want you all to understand, because this is out of experience, which I'm like talking now, that people know everything, but when it comes to actual practice, they feel a little jittery, and they feel, okay, I'm not very, this thing, and let me do a hysterectomy, leave a part. Dear friends, believe me, hysterectomy is not the answer for CIL, not the answer. Because that can be a false convincing factor that, tissue is out and it's fine. But you never know, no, patients have come back with vault carcinomas or VIN or VAIN. So how will you then convince this patient? She will not come back for you to follow up. So, and also another thing is very important thing to learn is medical legal laws. If you see, you cannot do hysterectomy for an unwanted, indications. So please be aware, and we give our homage, and we give all the contributions, tribute to these great scientists. George Papanicolaou brought us pap smear. Hans Enselman made us understand colposcopy, and of course, and Harald Zurison, we know that got HPV. And today what we are talking so much, and so many things are evolving around HPV, is all because of this wonderful, innovations and inventions. And then beyond that came up the vaccine with Ian Hector Fraser in Australia. So all these things are making us coming to now certain protocols. I have brought for you the latest protocols so that you know what's happening around in the world. So how do you treat? Where do you treat? Where's the expedited treatment? When will you do a colposcopy and wait, and all that thing? So let's go one by one. This is a wonderful ASCP 2019 guidelines. This is the latest, okay? And this has come up after a long trial from 2003 to 2010. Around 9 lakh women were kept under, all that thing has been done. That's called as Kaiser-Palmer trial. And this Kaiser-Palmer trial in California, the largest trial of cases, and they then came up with this type of understanding and a study. Now let's see this. What are they saying? That if your immediate SYN3 risk is more than 4, what will you do? Then first you will see for what is the immediate the risk, SYN3 risk. If it is 60 to 100%, you will do directly expedited treatment. You will not even wait for a biopsy. And I'm going to take you through all this. Don't worry. Like what comes into which categories. Then you understand that 25 to 59%, if there is an immediate SYN3 plus risk, then you will do an expedited treatment, or you do a colposcopy, wait for a biopsy, and then do a treatment. If it is from 4 to 24, you won't be in a hurry to treat, but you can do a colposcopy, biopsy, and then you can treat. If the risk factor is less than 4%, then what you do is you look at the 5 years SYN3 plus risk. So if that is above 0.55%, then you will ask her to repeat. You will ask her to come after 1 year and repeat her test. If it is written in 3 years, where it is, if the risk factor is 0.15 to 0.54%, then you will call her up in 3 years. If it is less than 0.1%, you will return in 5 years. So this is what they brought us, and we came to understand one thing is that they are taking 4% as the threshold. And with this KPNC data, that is Kaiser-Palmer California data, they have clustered this into 3 groups: about 25, just over 4, and less than. So we go to individual ones where we will be having the SYN3 plus risk of 60 to 700%. What all sits into this? HPV positive, HSIL. So here the immediate risk of SYN3 plus is 49% and immediate risk of SYN2 plus is 77%. If HSIL cytology, HPV 16, then the immediate risk of SYN3 plus is 60%. SYN2 plus is 77% and immediate cancer risk is 8.1%. And, so they have seen that if this strategy is being adopted, then 1.7% will receive a diagnostic excisional procedure for every SYN3 plus. So a low rate of overtreatment. So no problem. So they are happy with that. Then if there is a 25 to 59%, so which are the cases which are sitting here? HPV negative HSIL cytology. So you see SYN2 plus risk is 47%, SYN3 plus risk is 25%. HPV positive ASK-H, HPV positive AGS, HPV positive HSIL. So all these things they have understood that if they actually adopt this principle and go ahead doing a treatment, then 2.8% will undergo excisional procedure for every SYN3 plus treated. So a little bit of an over treatment, but that doesn't matter. So far, you're not missing out a case. And then if there is a colposcopy recommendation, just do a colposcopy. Don't be in a hurry to treat. So this is like LSIL and positive, HPV positive. And then you have LSIL, HPV positive ASCUS, HPV positive LSIL. So here you can, occurring our HPV positive NILM occurring at 2 consecutive annual visits. Just have a little bit over of 4%. Then where do you go for surveillance, as I told you? So HPV positive NILM, HPV negative LSIL, HPV negative ASCUS. Normally we get this type of cases. So here the immediate risk is very less, Then you can think about what you should do, when you should call her up, whether after 1 year, whether after 3 years, or whether after 5 years. Now you see, if this is another wonderful thing which I have brought for you all, which makes us understand when to call them. Say, NILM, the risk of getting SYN3 plus is. So overall prevalence actually of a dysplasia in a pap smear in a low risk population is actually so much. Overall it is 4 to 5%. So, but you will find NILM 96%, ASCUS 2.85. They have done a study. This all has come from this huge study. And you can see LSIL percentage, HSIL percentage is just 0.21, AGUS, ASCUS, and SCC. Now, how do you go for surveillance? Now, let's understand how to call. Say, I brought one This I have taken all these from ASSCP 2019 guidelines. Okay, you can go through it and you will find the same thing. I've just done copy, cut, paste to make you all understand how to take up. So this also was brought from there only. So they have written over here that initial screening, if you have done for a patient, she's HPV positive, ask us, what is her immediate SIN3 plus risk? It is 4.5%, which warrants a colposcopy. Colposcopy has been done. Biopsy result is say less than SIN2, less than SIN2. So what is her 5 years SIN3 plus risk rate? It is 2.9%. So what should be our management? We should call her up after 1 year. So 1 year she comes back for our follow-up. Here you have done she's again still HPV positive and she is ascus. Okay. So still, I mean, the same thing is prevalent. So what is her immediate SIN3 plus risk? It's 3.1%. So how will you call her up? You will call her up after 1 year. So that means now you have called her up next year. Now in the next year, what you have done, her HPVs become negative and NILM, then her 5 years SIN3 plus risk is not applicable because they have become. So you will call her up comfortably at 3 years. And if this HPV positive and ascus remains, then you will again do a colposcopy. So this is the methodology which people have been using abroad to understand the cases. Let's understand the evaluation of abnormal cytology and what plan we can have for ourselves. Say if the patient is having an ascus and her immediate SIN3 plus risk is 2.6%. You will call her up for 1 year follow-up. If she is ascus plus HPV positive, her immediate SIN plus risk is 4.5%. So you will ask for a colposcopy. If she is LCIL, her SIN3 plus risk is 5.2. You will ask for a colposcopy. If she is HPV positive and NILM, her immediate SIN3 plus risk is less than 4%. Here, either you can triage it with 16-18 or you just call her up after 1 year. If her 16-18 is positive, then of course you do a colposcopy. If now she is ASCH, her immediate SIN3 plus risk is 35%. So you will ask for excision because then she sits into that other thing, where you will be doing a treatment. So she sits into the 25 to 59% bracket, and there you go for an excision. HCIL again sits with 70%, which is 60 to 100% bracket. So you will do an excision with histopath. If it is AGAs and it's 30%, what you can do, again, they sit into the bracket of 25 to 59%. So either you can do a colposcopy, wait for the result. You will do an endometrial sampling. You will do an endocervical sampling. But if you're not able to do anything, at least you do an excision and give her for a histopath. Now, let's do an evaluation of normal, because see, we all in India still are onto doing a regular pap test. And let's understand, if we have a results, okay, of NILM or, normal cytology, then what is the risk factor of SIN3 plus? I brought all these dear friends from ASSCP 2019 guidelines, and I humbly request all of you all to go through the guidelines, because that article is truly, truly an eye-opener, and it's helping us to understand the case evaluation. So you have this as NILM, say, what is the SIN3 plus risk? It is 0.26%. So what will you do? So that's the reason you call her up every 3 years. If it is an NILM and HPV negative, what is her SIN3 plus risk? It is 0.08%. So that's the reason doing a co-test or adding up HPV really helps. You will call her up every 5 years. If she's only HPV negative, okay, now she hasn't done this thing. You have just done an HPV, and that's 0.14%. You will repeat it after 5 years. So now you can always download this app. This is the mobile app. Okay. And you can, this can tell you how to approach. Now I've got you another guidelines. Now this guidelines I've got to you, the latest 2021 WHO guidelines. Let's see what it is. And I have brought, according to each algorithm, one case for you all to understand how to take up the cases. So they have come up with understanding of screen and treat and screen, triage and treat. So what's this? So they are using HPV as screen and treat, but they are also using VIA as screen and treat. So I'm going to come to that algorithms as well. So if you're using an HPV screening and that's coming positive and you want to treat them. So what they're saying is understand the ablative criteria. That is, when you apply a VIA, just try to check out on the SCJ whether it is TZ1 or TZ2 or TZ3. If it is TZ3 and all, don't do any ablation. And no, if it is a TZ3, then go ahead doing an excisional. But here they are not doing any triage to understand whether there is lesion or not. They are straight away going ahead doing a treatment. And they're calling up after 1 year to do the follow-up. So that's a simple thing. Now, another thing which they have brought is screen, triage, and treat. So here again, if you're doing with an HPV, now this is with the HPV, and but there are also cytology triage that I'm going to get for you all, and VIA triage or VIA also. Again, I'm going to get for you all those things as well. So now understand that if there is a screen, triage, and treat, you've done a HPV, and that's come up positive. Okay. So how do you go about? So you can triage with doing a genotyping with a 16 and 18 positive. Even there is no lesion, you can treat it. You can do a VIA to understand whether there's a lesion. You can do a cytology, more than ask us, go ahead doing a treatment, colposcopy and like that, treat. So that's it. And they have brought for now, let us see the algorithms which are fitting into it. So we have now case discussions for see and treat with HPV and VIA, see triage and treat with. So now let's see the algorithm number 1. What's the algorithm number 1 for screen and treat? They are saying you do a VIA screening. If it is positive, kindly get the eligibility criteria fit, evaluated, and then go ahead. So if there's eligible for ablation, you go with an ablative technique. If it is not, then you go for LETS, okay? And you get a biopsy report as well. And if there is a suspicion of cancer, I had shown you last time also, how do you evaluate a suspicion for cancer? And we had seen that, bleeding on touch or a high grade, high suspicious looking with a high mosaics and breaking mosaics and all this, that's suspicion of cancer. And another thing which they have brought is when will you call them after treatment? You will call them after 1 year. Now, if it is negative, then you will call her up. Now, here again, a strategy has changed. You see, initially we used to call every 5 years VIA, but they are saying since the specificity matches to cytology, call every 3 years. Okay, so now the next thing. Now, I've brought one case for you. So, she's a 35-year-old with a white discharge. You can see VIA has been done for her. And this is the large lesion. So what we have done, this is such a large lesion, cannot be covering up in any of the ablative procedures, right? So I've done a LETS for her, you can see, and she was little bleeding from this area. So I've taken a stitch to treat her. I mean, treat that bleeding, take care of that small sputum. It was really irritating because ball cautery, nothing was taking care of it, but I had to take a stitch to stop it. So what is the histopath report? What I got was SIN1. Then we call her up after 6 months. We have done a colposcopy and we have seen that the report has she has become normal. Let's go to the second algorithm. You do a primary HPV DNA testing. If that's positive, you determine the eligibility for treatment. You determine the eligibility criteria for ablation, otherwise do an excision. If there is a suspicion of cancer, then of course you will evaluate her properly. So let's see this case. This is a case of 36-year-old menorrhagia in 6 months. She's a case of multiple fibroids, and initially her screening was done. This case was actually referred to me by one of my centers at Bandra. And because I'll tell you, this case was a very interesting case. So the screening has been done. She's HPV 16 positive, and I think she was asked us on PAP. My doctor tried to do a biopsy. My center doctor tried to do a biopsy with colposcopy, but she couldn't do so. She said, "Madam, please handle this case. I'm not able to do it." And she's not allowing and all that stuff. So I said, okay, fine. I take her up as a screen and treat. We haven't done a biopsy. And I said, let us take it up as a screen and treat. So let's see this case. So it's a very interesting and eye-opening case. She's 16 positive. All right. And what I've done is, this is the case. And you can see, I've taken a wonderful, huge LETS. And the whole thing has been out. What's the report? The report has suggested SYN3 HSIL and a small focal area of CIS also cannot be ruled out. That's what is written over here. How do I follow up this case? I will follow up after 6 months. I've called her up, and after 1 year, I'll do a test of cure. So that's how I will take up this case. We go to algorithm 3. Let's understand. Now, what's that algorithm 3 saying? Say you have a primary cytology. And suppose if she is ascus. Let's understand this very well, because many of us, even today, even in corporate hospitals, are still with cytology. How much ever we try to say that HPV should be the primary screening, but it's very difficult to have a changeover within, this thing. It takes a little time. All the changeovers takes a little time, and plus this is, as I told you, that it is it's less, it's cheaper than what we do for an HPV. So people are comfortable doing a cytology. So let's understand cytology very well. So you're doing a cytology and she is ascus. How do you take it up? You first start doing a triage with an HPV test. Now, if she's HPV positive with ascus, do a colposcopy. If she's negative, you call her up, She's just ascus and she's HPV negative. Nothing to worry. That's what the WHO criteria says. You rescreen in 3 years with cytology. Nothing to worry. She is just an ascus. And I can add one more thing over here. Suppose if your patient is non-compliant. See, because all these things are developed, people making guidelines, they have to see the broadest perspective. But we know what our patient, is, and how we are also not very comfortable having such type of results. So if you truly want, then you can go ahead doing a colposcopy. There's no problem. And if people do not have a colposcope with them, at least do a VIA to find out the tissue, lesions or something. So you have it over here, like if this, what they are saying is that if it is HPV negative, you call her up after 3 years and rescreen with cytology. And there again, if she is a more than ascus, then you do a colposcopy. And suppose if it is more than ascus, you will do a colposcopy and you will further manage the case. So let's see one case which I brought for you all. This is also a very good case. And in fact, this case was referred to me from the Kokilaben hospital with cytology stating as sketch. So this is a case which had come, she's for HCV positive for liver transplant, and as a routine, they do a PAC test. They had done a PAC test on this 59-year-old female, and they had found that to be HSIL. Now, this case is sent to me for colposcopy. And you can see what I have written over here. There's an abnormal blood vessels, dense acetovite area, rack sign, mustard yellow staining. And definitely when I did a biopsy, and we knew that this is all breaking mosaics also, you can see, as I told you. It's carcinoma in situ, severe dysplasia. Definitely, then she was evaluated further with CT MRI to find out. And then this case was a very important case because they wanted to know whether to do a liver transplant first or go ahead doing a Verdines for a. Definitely, we all know that doing, first of all, with a liver transplant and all, later on, she will be on immunosuppressive medications. So there it will flare up, and hence the first suggestion was go ahead doing a radical and then do your thing. So HSIL on cytology has to be evaluated very clearly. And I had even done an HPV for her. As a matter of fact, I told you, any lady who walks into my clinic gets an HPV. So that HPV also was very high positive. So this is one of the algorithms. Now let's go to another algorithm. Okay, now what is this algorithm? Now this algorithm is saying you have a screen, triage and treat. That's you do an HPV screening. You triage it with genotyping, all right? And 16, 18, and then you go ahead doing a treatment. So even though if you do not have a lesion Understand, dear friends, what does these things have come up, these guidelines have come up after lot and lot of experimentations and going through meta-analysis and a lot of experiences and evidence-based screening guidelines. So if you are able to actually inculcate these guidelines into your practice, it makes your life truly easy. So now this is an HPV DNA. If there's a 16-18 positive, you determine whether what is the right methodology of treatment for her. Again, how do you determine the eligibility criteria? That it should be, with this should be a TZ1 or max TZ2, and shouldn't be a larger lesion, or it shouldn't be, somewhere pointing out towards invasive CA, and it should definitely not be a endocervical lesion. So knowing these ablative criteria, decide on your treatment part, and then you can go for, if it is not suitable for ablation, you do a LETS and you get a histopath as well. And if it is positive, say HPV DNA positive and other high risk is there. Now the question comes is, if it is non-16-18 positive, then what will you do? You do a VIA triage, right? And if this follow-up steps after VIA triage, if it is negative, you can just call her up after 1 year and get her this thing evaluated. And if there is a suspicion of cancer, you will go ahead. So let's see this case. And this is again a very, very, very nice case. I was head HOD of one of the very, very good, high resource setting, where we had to screen 500,000 women for cervical cancer screening. This was from the Smart City project of Thane and Thane TMC. So this is again, this case is, she is a symptomatic lady, and she herself is a staff nurse. Okay. Nothing much. She just, she has heard, and she was all were instructed to get their screening done. So this lady walks in, she is asymptomatic. And as I just mentioned, it's a high resource setting. So we have set up all the biomolecular marker, even I have IHC tumor marker out there and mRNA and everything with me to, understand the cases well. So this is a wonderful thing. So we had this lady and her HPV was taken. And here we have a high throughput, 100 ladies walking daily for screening. And our staff nurses are trained to take up the VIA. So we were also doing an evaluation study to understand all that, So HPV was taken with Diogen method, and her VIA, unfortunately, my staff nurse told me that it is negative. And her HPV report came to me, which was saying with hybrid capture 571 RLU positive. So here I had triaged her with a genotyping. And of course, since I had mRNA with me, I had done it, and that was also positive. Now let's see this case. So you can see over here, I did a triaging with genotyping. And unfortunately, this was missed out by my staff nurse, who's actually been well trained. Her QC/QA we normally do every 6 months to analyze their this thing. But somehow, because it was a high throughput area and 100 to be seen VIA, somehow it was missed because she didn't wait for that 1 complete minute of evaluation. The moment you apply and everything is turning white, and she thought it's just an ectropion. But she had to wait for 1 minute, and that's how, this lesion was then determined. So this is a colposcopy which I'm doing. And what we have done while doing a colposcopy, the same sitting, I said, let's do a treatment for you. So we have taken from from bottom to up, and let's has been done. And what's her report? This lady's report, it's coming up as a mild to moderate dysplasia, SIN 1 and 2, and some places, this thing also. So now we had a relook colposcopy after 6 months. So she was mRNA positive, which shows the integrated HPV. Since she's 16 positive, and a very high RLU on hybrid capture. And you can see after 6 months, she's completely cured. So, and a completely asymptomatic women. See, and also, let me tell you, I didn't put it up here because I wanted to fit into the algorithms, but we had done her cytology also, and that was again NILM. So dear friends, what I want to get that take-home message for you all with these type of cases and eye-opening cases are, do not sit back doing cytology. Cytology के साथ कुछ ना कुछ add करो. If you want to do a cytology, add it up with an HPV, add it up with a VIA, because suppose see this patient had been only with cytology NILM. Huh? We would have forgotten her, we wouldn't have done her HPV. Definitely an mRNA positive. She would have come up within a few months in CIS or, in at least SIN3 and SIN3 plus rather, in few months. Whereas an HPV could make us understand the subject very well. So that's my humble request to all of you all. And then after 1 year, we did a test of cure and we found negative. What's a follow-up treatment is like, follow-up test after 12 months. So if you've treated her with ablation or LITs without histopath results available or with histopath results available, you will follow up after 12 months. If it is still positive, you can go ahead treating with an excisional again or do a conization, okay? And then again call her up after 12 months and then subsequently call her up every 5 years. Now, ASSCP guidelines has got some understanding that because these patients come with persistent or recurrent, the disease rates are quite high, they are calling the patients after 2 consecutive negative, they're calling every 3 yearly, if you're doing with HPV for, the remaining 20-25 years. But WHO, because these guidelines are for, in general, the whole globe and most probably in the LMIC countries. So there is a resource constraint, for screening or calling her up. That's why they have come up with an understanding they call every 5 years. Afterwards, okay, after your 2 consecutive results have come negative or at least one has come negative. And if it is negative after 1 year, then what will you do? You will put her back into the screening protocol. Then now I brought an algorithm, 5th algorithm for you. That is primary HPV DNA screening. You do a VIA triage. So let's see. You have done an HPV DNA. You have done a VIA triage. If it is positive, understand the criteria and treat it. If it is suspicious of cancer, then of course you will wait for a biopsy. You will understand the case and then only you will treat. Now, negative, rescreen with HPV test in 5 to 10 years for the general population and 3 years for HIV population. If it is negative, then again repeat the HPV test after 2 years for general population of women or 1 year. In this case, if you have treated, say in this case, like you have done a VIA triage, positive VIA triage. And say you have done an HPV DNA that is positive, you have done a VIA triage. And in this VIA triage, you have negative, but your HPV DNA is positive. What will you do now? You will call her up after 2 years for general population and after 1 year for HIV population. That means you are understanding how comfortably they have made us understand that Acha, if your HPV DNA is positive, doesn't matter, do a VIA, you see the tissue hasn't got any lesion, and you can then call her up comfortably after 2 years and get her HPV done again. If it is positive on the triage, you go ahead doing a treatment. If there is a suspicion of cancer, you can do a further evaluation. So now see, let's see this case. This is a 37-year-old with occasional postcoital bleeding. I have told you last time also, I had stressed that fact that postcoital bleeding, postmenopausal bleeding, these are high-risk stratification symptoms. Please see them, very cautiously and judiciously. HPV as a primary screening has been done. See this. And I have found 18 positive. What will I do? I've done a VI. And you see dense acetovite area. And when taken up a biopsy, it is a infiltrating squamous carcinoma. So in this way, you can truly take up cases and you can treat them accordingly. Now, algorithm 6, that is primary HPV DNA screening. You have a colposcope with you, so you have done a colposcopic triage and you have treated. So let's see this. Now, this is one case where 40 years old with reddish discharge. I've done an HPV for her and she's coming up as 18 positive. I've done a colposcopy for her and I'm seeing a lesion here, high-grade lesion, suite 6. This is coming to suite and it's a high-grade lesion and it's also going endocervical. So in this case, I had done a punch biopsy. I mean, I wanted to know the result. But of course, that doesn't matter because here just my dysplasia was seen. But I went ahead doing a treatment for her. I said it's a 18 positive and let me not take any chance. And I took up this case then and there. See over here, we have done a biopsy. Now here I've taken a pass from left to right. What is her histopath? It's suggestive of grade CIN2, CIN2. How do I do a follow-up? I call her up after 1 year and I do a test of cure and I find that her HPV is negative. Now, another last algorithm 7. Screen triage with HPV, primary screening, you triage with cytology followed by colposcopy. Say, now, if it is positive, cytology, HPV is positive, you do a cytology triage. If it's ascus or worse, do a colposcopy. If it is negative cytology, you can again call her up after 2 years in the general population or 1 year after in an HIV population. And let's see this case. Okay, now 32-year-old repeated post-coital bleeding. And this is it. She is 16 positive. We have triaged her with cytology. This is AS-H. So definitely I'll go ahead doing, a colposcopy. Now here, the sweating is very high. So I didn't go ahead doing a treatment. I could see the abnormal pattern and breaking mosaics. And definitely I said, I'll go ahead first doing a biopsy. And that biopsy has shown carcinoma in situ and the focal area of squamous cell carcinoma well differentiated cervix. So take home message, then we did a CT MRI and we found that this case was a little, in 1B2 case. So HPV as a primary screening tool is very, very effective. So dear friends, I come to the end of my talk and now normally whenever we are talking about, this thing, I mean, all these things I brought it from my book and now my 3rd edition is also coming. I have put up a lot of efforts in getting the 3rd edition with so many cases. As I'm telling you time and again, importance of having the right tool with you. That's very, very important. And of course, one of the, this I brought it onto the market because I patented this because see, whenever we are doing a lot of this LETs and all, no, you are supposed to hold the tissue. And you would have people who are truly into the subject and doing it will understand what I'm saying, that whenever you're trying to do a leap or, even thermal, you have seen even a punch biopsy, the tissue goes inside. You want to have a stabilization. There is a cuscose. You can't put a Alice or anything or tentaculum and hold it. You cannot because it's going to bleed again. So you do have, that's the reason I brought up this into the, I devised this like PGK, a traumatic Teflon coated tenaculum forceps. Of course, with a lot of training programs going across, I'm very happy to share with you that Mary Stopes, the global organization has, given a mail to me that we are now in India, we are the #1 training centers through Google. I mean, they did a Google survey and that was a very surprise to me. And in the globe, we are ranking 2nd after BSSCP. So that's something, very thing I felt very happy, that our training programs are taking up everywhere. So dear friends, it's not a dead end. This does have an alternative ending. And मंजिलें उन्हीं को मिलती हैं जिनकी सपनों में जान होती है. यूं ही पंख होने से कुछ नहीं होता, हौसले से उड़ान होती है. And never doubt a small group of thoughtful, committed citizens, they can actually change the world. So today, when you people are sitting over here and listening and trying to take this, seep it into you, and you're trying to do it, you are the people who's going to change the world and you're going to get that cancer mukt Bharat or, cervical, at least work towards it for the elimination drive of 2030. So thank you very much. And I leave you all with a ray of hope and let's see what we can do further. Thank you very much.
Sujita.
Congratulations, Priya. You are wonderfully explained the therapies for CIN, whatever stage wise, and really, and your own instruments are very innovative. I have seen also your, in our ICOG and that workshop at New Bombay.
You were there.
No, I saw your photographs on that, your
Oh,
instruments and on ISCCP.
okay.
And
Wonderful.
yes, after treatment, though whatever is the follow-up of the woman is also important, because that person has to be realized that yes, I have been treated, but I need to follow, because otherwise in our state of mind means women, they once they get treated, they never turn up.
Yes.
So our social workers' job is very important in our treatment product. These are also follow of these women. Thank you very
Correct.
much for this.
I will share with you one of the experience what I had, and again eye-opening experience that I had shown you that.
Yeah. Good evening.
Just a minute, madam. I'll call you back. I'm with Nagpur Society. I'll just immediately call you back. Yeah. This is a call from Tirchi to have a colposcopy workshop. All right, so let me come to you with one small experience, and there's again an eye-opening experience. You saw the video which I had shown you, and we had done a wonderful job. According to me, it was a wonderful job. And when we had all that, lesion margins free and all that stuff, I was very happy, And later on, after 3 years, and this lady didn't come back to me. After 3 years, she's coming back to me with another problem, absolutely different. Say fibroadenosis of breast or something like that. And I remembered her and I said, Arey, so you are the same person, you haven't come back for follow-up. Come immediately, let me check your cervix. She said, madam, I'm okay. I don't want to check it. I'm a very hi-fi lady, okay? Not that she's having any constraint of money or anything. She comes in a murk and in that way. Then I said to her, please come, and for my sake, I want to see your cervix so that I get convinced that no, nothing has gone wrong. And I didn't get that case for you, but I should have got that case. So when I saw her, I saw that white patch, small white patch, and I took up a leap there and then. And for my surprise, that turned out to be micro-invasive CA.
Oh my God.
Ooh. And I told her, look, Komal, you didn't come to me. And you should have come, and I've been telling you, I've written. And how I do is I write down the protocol. I give them those dates. They are supposed to come on that dates. And my staff nurse, they do a surveillance. They call them up. They get a tinker, they get everything. But then she wasn't. And then I told her, at least now allow me to do a conization further. So she said, madam, I'm what to do. And she was very this thing. And unfortunately, COVID and all came up. But then ultimately, of course, we did her this thing radical. But what I want to get back to you is, don't feel, you've done this thing, so there won't be any recurrence or persistence or anything. You have to keep them under surveillance. That's very important.
That is what I said.
And remove the whole transformation zone. And that's very, very important that you follow her up for 20 long years. That's very important. So that's the take-home message from my end. And I think we are well in time.
I think
Now you want to say something?
there are again 2 questions from Dr. Sandeep Phadke, ma'am. He's written, what are the indication for an MRI test, and can you please explain details about the test of cure?
I'm just reading the chat box. Sandeep Phadke. Where are you practicing, Dr. Sandeep? You have been asking many questions. I'm very impressed with you. You can open up your thing and talk to me. Okay. So, and what else he has written? There are 2 things which he has put up. Triaging undone to increase the specificity sense. Okay. trying to reduce over treatment. Absolutely right.
Whether he is there,
So-
Sandeep.
So if he is not there, what's the problem? I mean, he has to, then it is his main questions. Where Sandeep has lot of
Anyway, you can answer. Others will be treated.
Yeah, I'm going to answer that, but of course, I wanted
yeah.
Sandeep to be there to, get his doubts clear. Where is Dr. Sandeep practicing?
He's probably in Akola.
Okay. Okay. So see, mRNA. Let's understand mRNA well. I think in the people who are from ISSCP, they would have seen my article on mRNA. Chellapan, you had only put that article, shared it with everyone. So that mRNA is a wonderful tool. What it is, like how you do this genotyping or you do an HPV, no, it is the same thing. It's an HPV mRNA test, which makes you understand E6 and E7. Now, E6 and E7, if they are these IHC markers, no, these are those proteins which are leading to tumorigenesis, if that is there. So, there is an increased chance of getting into a high-grade lesion. And what we saw as a concordance in my study was, wherever there was, it is 100% concordant with your histopath, mRNA. So even if you have an mRNA positive and you treat it, with an mRNA positive, definitely then you are doing the right thing. But now mRNA is not available so freely. During those days when I was doing in 2014 and 15, mRNA was, we were doing a study. And I was getting it quite this thing, I was getting it. I mean, patients were paying for it, doesn't matter. So what does mRNA does? mRNA is a specific thing. Like, let us understand now, Sandeep has written triaging are done to increase specificity and sensitivity. Let us understand this very clearly. HPV is a high sensitive test. You are applying a test, you are getting true positives and false positives with a very good high NPV value, negative predictive value. So if the HPV is coming negative, then definitely you have a chance that, okay, you're for sure that there won't be any problem. Now, in the HPV positive case, you're applying another triaging method. Now, what are the triaging methods? This increases the specificity. That is, you're trying to remove the true negatives out. So what is remaining with you are true positives. And these true positives have a high PPV value. And that is why you're putting this triaging methods. So which are the good specific triage methods? Cytology, VIA, okay, mRNA or genotyping. All these are good specific methods. So if you are using these two, your chances of over treatment has reduced. So you're not in a very big hurry to treat. And that is exactly what Sandeep has also written. And you are right, Sandeep, you have asked a question. Is my understanding right, Priya ma'am? Yes, of course, your understanding is right. And I'm happy that you're getting the right messages out of this type of lectures. Yes.
Then what is taste of cure? He's also asked another question. What is taste of cure?
Test of cure is when you've treated. Did you treat well? Is the tissue treated well? That is test of cure. So normally for test of cure, you always do HPV test.
Okay.
And you can take it after 1 year.
I have another question, ma'am. See, many a times the HPV infection is cleared off on its own, many a times. So why are we so worried about this HPV infection?
Yeah. So very nice question, Rujita. Why should you treat so aggressively?
Aggressively, right. Because 90% of the infections will be cured.
Very correct. So let us understand this very well. Why this aggressive business has come up? Because WHO has put up an elimination call 2030. So they are very aggressive onto treatment. Do you want to be aggressive? No, I don't want to be aggressive. I will go smoothly. Okay. Another thing. How many cases are coming back to you? Are you sure about it?
No, absolutely not.
That's why become aggressive. You got the answer.
Okay, ma'am. And one more question. While we do lids, we often have this problem, the vision gets blurred because of that smoke. So do you routinely use suction pipe?
Without that, I don't do.
Right.
You have to connect it to the smoke evacuator or the suction. Use the insulated cuscos and do it.
Right. But the posterior blade is longer than the anterior for stability.
Absolutely.
So that's a
Anything
wonderful
else?
question, ma'am. Thank
Priya
you
ma'am.
so much.
Priya
Yes.
ma'am.
Yes.
Good evening, ma'am.
Hi,
Aarti from
Aarti.
Varanasi, ma'am.
I
Fine, ma'am.
know. I know many of you all are all my, routine, the thing I have seen.
Yeah. Ma'am,
Coming, then
just wanted to
submitting.
share one experience.
Yes.
Do you also find the cases of CIN, or you can say positivity of VIA or cytology is going down day by day? What I'm finding in my screening,
Come back, Aarti. What did you say?
like I'm
I'm sorry.
finding less cases of VIA positive, cytology positive, and HPV positive nowadays, since last 2 years or 3 years, you can say.
Must be because we are screening well now.
Yeah.
Or I do not know. I mean, I can't give you an answer upright because in my case, now see Kalpana Pandey from my one of my mentorship training doctors, our franchisee chain. She is from Kalpana is from Barabanki and she is also there in this. She's from Barabanki, Lucknow, that area.
Yeah.
There we are finding very high cases of HPV.
But
And my centers where we have across 30 centers across the country, I mean, actually, we are seeing rates have increased. That is, might be because we are screening more.
Yeah.
It might be because now we are a recognized centers, sort of people are looking to us, to our centers as exclusive centers,
Okay.
Might be that also can be the reason. I'm not negating the fact, but in my thing, I'm seeing a little bit of a higher thing which has increased, sort of thing.
Maybe they are using the higher method like HPV testing or.
Yeah, as I told you, our centers, none of the case will go without HPV test.
Yeah, but we are using cytology and VIA, that too in the rural areas. Huh?
I feel that's again, I mean, I'm saying, please come out of this. I mean, I would really request all of you all if all these efforts which I'm putting across the nation, without even seeing my time and energy, I'm putting all my efforts. Even if I understand if the doctors have taken HPV on their pen, I would be the happiest person.
True, ma'am. I'm agreeing to you, but the thing is, while screening the mass population, it is very difficult to go for the HPV testing
Then do
or
VIA.
even for cytology.
Aarti, then do VIA. Why am I not saying that? You have a mass population to screen. Okay, I have 50,000 people to screen. I don't have money. Do a VIA, no?
Yes, I'm doing VIA, ma'am, routinely. I think I have already done 126 villages already I have covered.
Excellent work in Varanasi. So when you're doing this, use VIA. See, I've been doing this SSNPP programs. And in that SSNPP also, many of you all keep on joining to understand the VIA interpretations. If you truly go by these VIA interpretations, and you understand that, I don't think so. I know that VIA again is a subjective matter.
Yes,
many a times either
this
we
is
are
the
over treating or under treating.
Biggest disadvantage of VIA. It's very subjective.
So QC QA is very, very important. And now with that EVA tool and all our and other tools also come with an AI, they are also helping us for this VI. Oh, that is there. But Mrudul is saying, but HPV test is expensive. Again, I would put it up on records that HPV test is not expensive. You are doing it every 5 years.
True, madam.
I get cases from Adivasi villages and all. I tell them to accumulate money. I tell them if you truly want one understanding properly, you put your kitty, put little money, 200, 300 rupees. They, accumulate for 6 months or 7 months and do one thing which is actually good.
HPV testing.
HPV test. Rather than becoming too much, into it. That's how we have been doing, and I've been really, we have done
most of the labs, they are charging 3,000 or 3,200 for HPV testing.
Now see, we, for that also there are the things, so you have to use validated tests. That's absolutely goes without saying.
Actually, madam, what I'm doing is that I'm doing for the NGO, Indian Cancer Society. So what tests they are providing, I have to follow. This is the biggest problem. what I'm facing in my.
EIA and get it done, sorted out.
Yeah.
So, thank you very much.
Thank you,
And
ma'am.
Thank you,
yeah,
ma'am.
thank you very
Thank
Bye,
you
much.
so
ma'am.
much.
Bye, ma'am. Bye.
And
That was really
thank
very
you so much, ma'am. Thank you. And excellent discussion and very stimulating discussion, I would say. And we are looking forward to the next session
It's Monday.
again on
you, ma'am.
very focused.
I
So
think you're
thank you
not
so
bored
much.
of my things, huh?
Sangeeta,
I think you're
you
not
want-
bored of all that sessions going on and on and on.
Absolutely not. Absolutely not,
Not
ma'am.
at all, not at
We are
all.
looking forward. With
All
such a difficult topic, you made easy one of the comments in the chat boxes, like very nice
Yes,
interactive session.
definitely.
Thank you very much. We
Thank
meet
you so
on-
much, ma'am.
Thank you,
Thank
ma'am.
you.
Thank you, ma'am.
Bye.
Excellent talk, ma'am. Excellent.
Thank you.
See
Bye,
you
ma'am.
next Monday.
Monday, yes.